Next, we will talk about neuromyelitis optica. There's typical neuromyelitis optica, which we all know about, in which there is transverse myelitis and bilateral optic neuritis. The symptoms may occur at once or be separated by days or weeks. The importance of diagnosing neuromyelitis optica is that the treatment is different from the treatment for multiple sclerosis. So you treat NMO with monoclonal antibody agents, not with steroids or interferon. And there is suggestion that the treatment for multiple sclerosis, if applied to neuromyelitis optica, can make it worse. So it's really important to distinguish these entities. In NMO, there are aquaporin 4 antibodies, which result in damage to the astrocytic water channels in the periependymal and perivascular regions. So there are major criteria and minor criteria for typical NMO. The major criteria, of course, is when there's optic neuritis. You can have either one or both optic nerves involved, as well as transverse myelitis. And with transverse myelitis, you have spinal cord involvement greater than 3 levels. It's extending through the cross-section of the cord. NMO typically occurs in the upper cord, so cervical or upper thoracic spinal cord. There is a different type of NMO associated with anti-MOG antibody that can involve the lower cord as well. It's important to know that NMO is a diagnosis of exclusion. We have to look in the clinical history to make sure the patient doesn't have a history of sarcoidosis, vasculitis, lupus, or Sjogren's disease before giving this as a diagnosis. In my personal experience, it's good to suggest a diagnosis with transverse myelitis of unknown cause in patients who don't have other known cause for the transverse myelitis, because it's very easy with a simple CSF or serum test to diagnose this disease, and it changes management, even if there is no concurrent optic neuritis symptoms. There are minor criteria as well for NMO. It's important to do a brain MRI if the cervical spine imaging is suggestive of NMO, specifically if there's transverse myelitis. NMO does not have MRI brain features suggestive of multiple sclerosis and has more typical features, which we'll go into in more detail later on. Additional minor criteria includes a positive serum or CSF test for aquaporin 4 antibodies, as well as anti-MOG antibodies, and MNO IgG antibodies. There's also something called neuromyelitis optica spectrum disorder. So these patients can have NMO without the optic nerve and spinal cord involvement. These patients may or may not have the anti-aquaporin 4 antibody. So this entire spectrum disorder includes the typical NMO, but also includes optic neuritis by itself, longitudinally extensive transverse myelitis, or some combination of the two with systemic autoimmune disease. The brain lesions typical of NMO involves the hypothalamus, the corpus callosum, especially the splenium, the periventricular white matter, and the brainstem. Compared to multiple sclerosis, NMO lesions tend to be larger, more confluent, and edematous. These lesions typically occur after episodes of optic neuritis and spinal cord lesions. The brainstem lesions are typically dorsal and in the periaqueductal regions. These are regions with higher concentration of aquaporin 4. The aquaporin 4 is also in higher extent along the medulla. So again, NMO lesions are in higher frequency along the dorsal aspect of the medulla, along the area postrema. And this is much more commonly in this location in other demyelinating diseases. And the brainstem lesions are usually asymmetric or unilateral. So the NMO spectrum disorder you can have caused by anti-MOG antibody, which is an anti-myelin oligodendrocyte glycoprotein antibody, and it has been found in some patients without the anti-aquaporin 4 antibody. Differentiating NMO spectrum disorder and multiple sclerosis, again, is important. Here's a brief table describing the differences between anti-aquaporin 4 and an anti-MOG antibody. The key difference is that the patients with NMO spectrum disorder with anti-MOG antibody tend to have more frequent optic nerve neuritis and involvement. Spinal cord involvement is more common with transverse myelitis and anti-aquaporin 4 antibody. And in addition, the swelling and enhancement is more significant with anti-aquaporin 4 antibody than with anti-MOG antibody. Anti-aquaporin 4 antibody has a female predominance of greater than 90%, whereas the anti-MOG antibody variant of NMO spectrum disorder is fairly equal. Even the CNS lesions can be slightly different between the two, with the hypothalamus and the periventricular white matter, as well as the basal ganglia and the area postrema, more commonly associated with the anti-aquaporin 4 antibody, and the cerebral cortex, pulvinar, and paralimbic lesions more commonly involve the anti-MOG antibody. Here's a case for your review. Here's a 51-year-old man with left monocular vision loss, previously had a history of right monocular vision loss. As you can see here, there is subtle enhancement involving the left optic chiasm with T2 hyperintensity. The right optic chiasm also has T2 hyperintensity but does not enhance. And you see a long segment of cord involvement here. So the time course between the two, this study was done in 2014 and this one was done 5 years earlier in 2009. Once we had seen the imaging findings in the more recent MRI in 2014, we thought that this was a patient who had NMO spectrum disorder. His anti-aquaporin 4 antibody was negative. So he was diagnosed with seronegative NMO, had altered mental status years later, and this is from 2016, so 2 years later, you can see these T2 hyperintense demyelinating lesions with incomplete enhancement involving the cortex and no perfusion increase in the regions of enhancement. And again, you see the typical feature of a tumefactive demyelinating lesion in which, for the size of the lesion, there's very little mass effect. You wouldn't expect to have tumors have this little mass effect. And there's very little displacement of vessels. So again, this is very characteristic imaging findings of a tumefactive demyelinating lesion. And so these are multiple tumefactive demyelinating lesions related to NMO. And then this progressed further. Here you see it's involving the corpus callosum. There's intrinsic T1 hyperintensity, there's diffusion restriction. And at this point, there were some questions about whether this patient had multiple sclerosis. It's sort of open to interpretation at this point because, as you know, multiple sclerosis can also have involvement of the corpus callosum, and the clinical team was still looking into that on the more recent notes. Okay. Here's a companion case. This is a woman who had left-sided acute weakness, history of rheumatoid arthritis on methotrexate and infliximab. Here you see there is this T2 hyperintense lesion. Again, not very much mass effect. Fairly small amount of mass effect for the degree of white matter. Signal abnormality. You see that it's involving the white matter abutting the third ventricle and along the white matter of the periventricular white matter. It's also extending to involve the thalamus, the subinsular regions, going into the brain stem, into the medulla, into the midbrain. And you can see there's diffusion restriction along the ventrolateral thalamus, and there's T2 hyperintensity here along the right parietal lobe with some areas of enhancement. So initially there was no contrast enhancement on this study, which was done on October 1st. But then just 2 days later, you can see that there's enhancement here. This was biopsied and shown to be demyelinating disease, and the NMO antibody was positive. So this is another case of animal. And here's the patient. After the biopsy, they decided to go ahead and do the cervical spine MRI and the thoracic spine MRI. And you can see transverse myelitis here, long segment cord involvement involving the whole cross section of the cord, extending throughout the cervical spine and into the upper thoracic spine.